And those case studies actually were really interesting from our perspective, because it just tells us what we need to think about and what data we need to look at for patients when we dose and dose adjust, and obviously use therapeutic drug monitoring to inform us. One of the questions I had from your presentation was use of continuous infusions at I think there are 9 adult ICUs, and whether you do use them, and if you do you change your targets at all, or do you still look for the same target exposure?
Thanks for that question. We do not use continuous infusion for any beta-lactams in our center. It is only recently that we have started to move more towards extended infusion, but it's not for all patients. It's more in response to therapeutic drug monitoring results. But with that, there has been some inertia that people feel more motivated to use prolonged infusion up front. But currently, we are not doing any continuous infusion, and thus have not made any recommendations to tailor or serum concentration monitoring accordingly.
That's really interesting, and obviously the data is very much evolving in that area, and so it's interesting to see when you said that beta-lactam therapeutic drug monitoring is something that is building evidence, but obviously the uptake of it is I suppose there is a level of lag, but at the same time, it's a bit chicken and egg. We need to have that data to help inform practice and vice versa. So it's one of those things that I think as the data accumulates, we may be able to have some more specific recommendations.
If I may just, may I just finish that comment by saying, I think sometimes people get stuck on the discussion about the assays. And certainly I acknowledge that it's very hard to do this without access to assays with a reasonable turnaround time. But often those same people who will debate the merits of beta-lactam TDM, if you tell them, let's just pretend you have the assay. Let's ignore the fact that you have to get it, but let's just pretend you have it. Would you use it? Those people will say yes. So it's a like you say, it's a chicken or an egg thing. But if you can get people beyond their own persuasion to argue, and you just say, listen, do you think that there is value in this? I mean, you look at enough cases, you see that there are clearly patients on the tails who need it. And so if you can just get people over their own reservations, I think that can be a huge step.
Thank you for that, Erin. That's very valuable. And it actually flows on really well. That comment flows on really well to one of the questions that's been posted online that I might get Emmanuel to have a look at. And it's, should we really be chasing mortality as an outcome? And I think that was based on his question or based on his presentation, which is looking at assessing the utility of beta-lactam therapeutic drug monitoring. And I think from his view, and I would like to hear this, as a clinician, what are the things that he's looking for to quantify the utility of beta-lactam therapeutic drug monitoring?
Thank you for this interesting question, but quite tricky to answer, obviously. As I said, I think mortality is not a good outcome for several reasons, especially because there's a lot of confounding factors that will influence, in the end, mortality of an ICU patient with infection. But as it was recalled by Professor Barreto, when you ask physicians which outcome they are interested in, especially if they are non-experts for PKPD or TDM, for example, they seems that they are only trust mortality as an outcome to change their mind. But it's very tricky. It was observed in the survey of the Mayo Clinic, and we have the same answer in a study we conducted 2 years ago, and we asked some intensivists about mortality for TDM. So I think it will be challenging to not to try to prove this decrease in outcome, but I think it will be tricky, not to say impossible. But I think during the second phase of sepsis, not during the first 2 days, there is a lot of things to do, especially for toxicity, and which threshold. It has also been reported by Professor Barreto. It's quite challenging. And we know that there is a high occurrence of toxicity during this particularly phase after 2 days. And we need to look at this together. And maybe we can add some economic evaluation, because if we are able to decrease the toxicity and ultimately occurrence of adverse event and the length of stay, it could be a positive argument for TDM, especially for beta-lactam TDM. But yeah, mortality, I think it will be very, very tricky. But I fear that it is the only thing to convince all of intensivists, especially because I know this is my colleague are like this, and it seems that this is also the case in the United States.
Aaron, any comment that you might want to have? I mean, one of the things that I always think about, and when I heard that there were 9 adult ICUs in the Mayo Clinic, something like a step-wedged approach to implementation of therapeutic drug monitoring to quantify perhaps the economic or do an economic evaluation. Was that something that you were thinking about, or some of the people were thinking up from a very macro point of view at all?
Yeah, I'm very privileged to be in a resource-rich setting, and so I don't want to take anything away from that good fortune that I have. I do think the economic piece is certainly very important and is often a barrier for individuals. But I guess I would go back to this unusual bar that we set for beta-lactams, that we really don't hold all antimicrobials to. I don't think, I'm not aware, and perhaps I haven't dug into the deep archives in the belly of the internet on this, but I'm not aware of a compelling study that shows that vancomycin and aminoglycoside therapeutic drug monitoring improves mortality. I think we can certainly make persuasive arguments for why it is indicated, but I don't know that some of those bars that we set for beta-lactams are at all reasonable. Indeed, mortality is a function of your goal of care, right? Some people want to die and die with dignity. And so that's not something that has anything to do with my PKPD program. And so I do think it is an interesting question. I'm not sure what level of evidence we're going to be able to create, but I know that the inertia is there. I think that there are too many voices who are interested in this, and so it will come. I think we are just able right now only to see the zoomed in early phase of this world that has only launched in 2010.
Thanks for that, Aaron. I might we've talked about beta-lactams for a little while now, so I might change track and go on to voriconazole. So I've got a question here for Julian, and one of the questions actually stems from when I was just Googling up clinical practice guidelines for TDM of voriconazole in Asian patients, and I came up with this this practice guideline that was published in Clinical Therapeutics in December 2022, where at the end of it they've said the findings based on obviously they did a bit of a search of studies, and they said the findings indicate that therapeutic drug monitoring is strongly recommended to prevent adverse events in Asian patients, and therapeutic drug monitoring is generally recommended for non-Asian patients to address subtherapeutic concentrations. Is that a fair assessment based on the data that you've seen, and obviously the genotyping that you're doing a lot of excellent work on, especially with the real-time dose adjustments?
Yeah, I mean, it's generalized for sure, but Asian populations definitely have a much higher proportion of the poor metabolizers, and so you'll often see, well, I guess 1 in every 3 Asian patients that is a poor metabolizer will have much higher levels. Will have much higher levels. So you'll have a much higher incidence of supratherapeutic levels creating toxicity. And in saying that, they'll also have a higher chance of having therapeutic levels. But I think that 30% still not that many, and that I just, as a whole, would recommend that all people have pharmacogenomics tested and levels tested. And also because it's easier just to have one standard set of rules. I mean, if you work in clinical practice and you want to keep things simple and you want to know what the thing is to do, the number of variables to have to go through a protocol to go, are they this, are they that, do I test, do I follow up test, all that sort of stuff. I like to sort of capture everyone and just keep a clean rule for everyone. But yes, they are higher risk of higher levels.
And based on what you've said, that your real-time PCR testing for the pharmacogenomics component of it, is that data going to be forthcoming soon, Julian? Because we're all excited. When I heard that, I thought, wow, that's an amazing innovation to be able to do it. We always talk about real time, and pharmacogenomics is not something that I have a very good handle on, but it's something. Yeah.
I think it's going to be a little while until we can get enough patient numbers to show any real benefit. We'll definitely not be looking at mortality as an outcome, because we're going to need a lot of patients to look at that. But unfortunately, I mean, look, it depends how you want to use it. There's definitely enough data out there to just use the test. And right now, the real challenge is moving it from that stage where it's available test to really like what is its place in clinical, what is the clinical application of the test, and how can we expand the clinical application? It's challenging because by doing it real time, it's much harder to batch, and so it's much more expensive. So the economic implications of doing that are obviously higher. Yeah, it'll probably take a little while before we have enough patients of when we start it up front. And there are a lot of centers that I know of that are already using it as far as they have their problem patients, and potentially it could be something like if it's for prophylaxis, or if it's for someone that's not symptomatic that has a suspected fungal infection, and you're not too worried about getting a level within the week, within 2 weeks, to go ahead and not use the pharmacogenomics test after 5 days if that level is undetectable, then to use it. I mean, that would be much better economically. But again, the more criteria there is, the harder it is to sort of roll it out. And so really, like right now is where that clinical applicability of the test sits, is being decided, I should say.
I've got a question here on one. I'm referring back to our Q&A online questions, and a really nice question by Yana, who there's 2 parts to it, and the second part is actually going to be addressed in our evening session, and that's looking at beta-lactam and Cipro model-informed precision dosing in combination with therapeutic drug monitoring, that was published by Ewald and colleagues in intensive care medicine in 2022. So I might leave that question off there, but this question, Julian, is for you, which is interested in the panelists' thoughts on the multi-center RCT, voriconazole model-informed precision dosing with therapeutic drug monitoring, published by Veringa. And I think it's published in 2023. Did you have any thoughts on that at all?
No, because I'll have to look at it, because I'm not familiar off the top of my head of
Sure.
that paper. Sorry.
Well, that's fine. And as soon as I saw the date, I thought, oh, this could be a tricky one for the panelists. But I'm doing my full disclosure and letting the audience give their questions as they see fit. She's also had a follow-up saying, would love to hear Ron's thoughts. Now, I'm not sure if it's on that topic in particular, but I do have a question with respect to one other online question, which is, how can existing data within EMRs be used to integrate with these models? Ron, that's probably one of the questions that has come up, and there's going to be maybe a couple more before we finish up. So.
Sure. Maybe to go back to the previous question, I also did not read that specific paper, but maybe I could make a general remark about that, is that for these studies where you really look at model-informed precision dosing, so not only using TDM, but also on top of that have like a Bayesian tool to predict into the future, it's extremely important to do a model validation step before you start the trial. And I don't know if that has been done for all of these trials, but yeah, you need to make sure that these models actually are accurate and are predictive. Otherwise, it's another reason why the trial could fail. But that's more. I don't know the specifics of the trial. So on the other question that you asked about whether we can and how can we use data from the EHR. Yeah, sure, we can, and I think there's a lot of angles to that specific question. I think we don't have the time to go into all the angles, but maybe one angle that I would like to highlight is you have to be careful of overfitting the data, and it's very easy to basically extract all kinds of data from the EHR about the patients in your hospital, and then you build a nice model and you show that it works in your hospital. But it's always hard to let me just change my camera. Oh. It's what we often see is that the predictive ability of that model in a new population in another hospital maybe, or even in your own hospital, but over time it actually becomes not so predictive at all. We've seen many examples of that. So that's something you really have to look into. That's very important. But yeah, there's a lot of other angles to whether you can actually get the data, how do you get the data, is there any issues with privacy and things like that. So there's a lot of angles to it.
I have one more question for you, Ron. I think you presented some information on the machine learning ability to predict pharmacokinetic parameters. And I believe it was on a study that was presented that used 2 to 3 samples and showed comparable efficacy. What sort of patient sample size? Because whenever I think of machine learning and AI, I always think of big data to help inform it. But I wasn't sure, I didn't get a feel of what sort of sample size was used to help inform that.
That's a good question, and that's immediately, I think, one of the limitations, because when we build PK models, we can even build them on maybe 15, 20 patients if we have to, as long as we have a bit of for each patient we have a few samples and we have a bit of a spread in age and renal function or something, then that could be enough already. But machine learning models, you need hundreds of patients, if not thousands of patients. And for this particular example that I showed from this French group, I don't know by head how many patients they had in their data set, but it must have been thousands, because they've had this TDM advisory program for 15 or 20 years or even longer. So they had access to that whole data set. And so this first example was not vancomycin, it was for tacrolimus, but still they probably had thousands of patients to train the model on. Yeah. And that's one of the limitations of that approach immediately. Yeah.
I'm just scrolling through some of the other online questions. Thank you all for your responses. And I think we might have time for one more, if that's okay. Yeah, that's fine. And we love our beta-lactams here, by the sounds of it. So one more question for you, Erin. It's a question actually from one of my PhD students, Quinn, who is doing a lot of work in pediatrics. And so her question is really more a general question, which is, for those patients with higher beta-lactam concentrations that were observed in the Mayo Clinic, did we see any clear adverse effects or just potential adverse effects?
Thanks for that question. So high beta-lactam concentrations are a little tricky conversation, I suppose. Some people have very strong feelings about it. I would offer that, so we had between 6 and 20% that exceeded our safety thresholds, and our safety thresholds varied across drug and across time. We evolved our understanding of it. In general, people use the threshold of 8 times the pseudomonal breakpoint, or 64, for example, for cefepime as a magic number. But then if you look into the literature, it changes across drugs. So we ended up modifying. So now we just use easy numbers for people to try and remember. Recall, I have a lot of pharmacists, so we're trying to get people to get comfortable. So we say cefepime 50, piperacillin 150, meropenem 30. Those are our magic numbers for toxicity. And when we looked at people who were in excess of those concentrations, we didn't have any clinical episodes of toxicity, although one could suggest that the therapeutic drug monitoring perhaps prevented that, because if you look at the case that we showed, assuredly that patient would have been at very high risk for toxicity if she had stayed on the cefepime unadjusted. And so it's hard to say whether the TDM was impactful or not, but one could guess that it was. In general, if we look at critically ill patients and we take away all of the million jillion confounders that affect neurotoxicity or our definitions of neurotoxicity, I might even offer, it's only about 2 to 5% who are actually really toxic. So it's pretty infrequent in general and hard to find. And our ability to predict it is very poor. It does appear to have a concentration dependence, but there is no direct threshold that has been well established. It does appear to be affected by baseline cognitive dysfunction, maybe weight, maybe age, maybe kidney dysfunction, but you can have toxicity at normal kidney function and at normal drug levels. And so the long answer is we didn't see toxicity in these cases, and also the toxicity in these patients is hard to find and poorly understood.
Maybe one for accumulating a lot of big data for AI and machine learning down the ages, but yeah, like you say,
that would be wonderful. That would be wonderful. If we could label it well, that would be a really nice way. A very, very large study would be necessary to look at it rigorously, but there is a lot of data out there to do it. Maybe Ron can help us. Ron will help us.
Well, look, I might finish it up there. I think it's been a really great session. Erin, Ron, Julian, and Emmanuel, we really are grateful for your presentations today and for taking time out, particularly for our Northern Hemisphere presenters in the States. It's not easy to get online and present at this time of the evening. We have lots of other things that are going on. So we're very grateful for you to be here, and we're also grateful for the audience, both online and here with us. And just want to remind everyone that this is the first session of our Worldwide Precision Dosing Seminar. We've got another one in 6 hours. So it's at 5 p.m. on Brisbane time. And we hope to see you there. So thank you very much.